And finally, coming to the last section of our topic of portal hypertension, that is the treatment of portal hypertension. So, the treatment is usually aimed at reducing the blood flow within the hepatic and the portal vein. It's done with the help of pharmacological methods, and then also noticing that we need to reduce the resistance within the liver. This is also done with the help of pharmacological agents. And then there are some techniques such as the radiological techniques and the surgical techniques done to prevent the portal hypertension for once and for all. So if we talk about the pharmacotherapy, so like I've mentioned that the drugs used in the treatment of portal hypertension, it recommends the and it causes the decrease in the portal blood flow. So what are the drugs that are involved in these are the non-selective beta adrenergic blocking agents. Then we've got the somatostatin and its analogs, the vasopressin and the terlipressin. And then if we talk about drugs that decreases the intrahepatic resistance, so these both things are very important. The blood flow and the resistance are supposedly they should be decreased, and then this causes the decrease in the pressure. These includes the drugs such as alpha-1 adrenergic blocking agents such as prazosin, and then angiotensin receptor blocking agents and nitrates. So these are the list of drugs that aim at reducing the pressure with the help of reducing the blood flow and reducing the resistance within the liver. So, if we talk about one of the methods to control the esophageal varices, like I've mentioned previously, sclerotherapy is one of the methods to finally contact varices and get rid of it. So, this is a diagram of esophageal varices. So, as you can see that this is the esophagus before the stomach, and these dilated veins, they are the esophageal varices. And as you can see that there is one bulge within the vein, and it is this one is notably called as the esophageal varices. So sclerotherapy, what really happens is that it includes some planted by endoscopic band ligation. So it usually occurs with the help of an endoscope. And first, mostly what do we do is that we inject the specific area of the esophageal varices with a sclerosant. So the sclerosant usually involved is the sodium morphoate or solely just alcohol, and this causes the area to for the esophageal varices to sort of dampen the effect. And then lastly, what happens is that after injecting, the esophageal varices could reduce slowly and occasionally. So the complication with sclerotherapy is usually bleeding, strictures, and perforation. Coming to the variceal ligation, this is also a very interesting way to get rid of an esophageal varices. What really happens is that there is a on at the tip of the endoscope there's a suction cap, and then if we notice esophageal varices, the it is pointed towards the esophageal varices, and that part is sucked with the help of the cap. And then when it is sucked and it is in contact with the tip of the endoscope, there is a band that is transferred to the stalk or the root of the variceal part of the esophagus. And then after having the band ligation, what happens is that it strangulates the varices and ultimately causing thrombosis. So this sort of techniques usually done for the varices that are bleeding, or if there is a re-bleeding of the varices. If we talk about the complications of variceal ligation, it usually causes esophageal ulcers and dysmotility of the esophagus. So coming to detachable snares and clips, these usually they're done in patients with large polyps, such as patients with large polyps in the colon, but there is very limited experience of these snars and clips within the esophagus. This also, what really happens is that it causes a traction of the esophageal varices, and then there's the detachment of the snare, and these snares, they are attached to the esophageal varices. So in the future, if we see the possibility of removing these snars, so they are also detachable. So the snars and clips are also involved in the treatment of the esophageal varices. But the only problem with this is that it also causes disturbance in the visualization of the endoscope. So that is the reason why it's not usually done for the esophagus, but it's done within the colon. And then we've got the balloon tamponade and stents. So this is usually done for as a temporary method. It's a temporizing measure until the ultimate treatment, that is the tips, can be carried out. In this, varices are usually easily compressed as they are very superficial. So what really happens is that we pass on a tube, which could be the Sengstaken Blakemore tube, and after passing the tube, we insert the esophageal balloon port and the gastric balloon port, and then after inducing it, there is a pump that helps in pumping and inflating these balloons, and then these balloons are inflated within the esophagus or the gastric part of the digestive tract, and these then causes the esophageal varices to be compressed for a limited time until the tips can be carried out. Lastly, the TIPS, which is the transjugular intrahepatic portosystemic shunt. This is the ultimate treatment of portal hypertension. What really happens is that it decreases the portal pressure by creating a communication between the hepatic vein and a part of the portal vein, that is the intrahepatic part of the portal vein. So after forming a connection between these two, it causes a compensation, and it causes a compensatory method so that the collateral circulation is not involved and esophageal varices are not made. So as you can see that this is the liver, we've got the hepatic vein and we've got the portal vein, which and the part that is within the liver is called as the intrahepatic part. And then what happens is that we pass on a catheter with the help of a guide wire through through the inferior vena cava and then into the hepatic vein. This could be done through an transjugular approach or through the femoral vein. After passing on the catheter, we try to involve and try to pass it on into the portal vein. And then after passing on this guide wire, what happens is that we pass on the stent. So the stent is usually inserted and placed between the hepatic vein and the portal vein. As you can see in this picture that there is a stent that causes a communication between the hepatic vein and the portal vein. So this usually is done by an interventional radiologist who'd be able to do this with the help of some endoscopic procedure or through some CT scan. The needle that is inserted as a guide wire, it is also called as the Roche needle, and ultimately this prevents the formation of complications. So this is one of the major setback that causes the complications such as the variceal bleeding and ascites to be reduced to a very low level. So that is the reason why TIPS is the ultimate solution of the portal hepatic hypertension. So this brings us to the end of our lecture of portal hypertension. Giving you a summary, we've studied about portal hypertension, what is the definition, what are the different pathophysiological features, what are the clinical features, And then how are we going to diagnose a patient with portal hypertension? What are the diagnostic criterias? And then we've talked about esophageal varices, the specific treatment for esophageal varices, and then we've seen that, well, the drugs that causes a decrease in the blood flow and decrease in the resistance within the liver, and ultimately causing a decrease in the portal hypertension. I hope you've enjoyed our lecture today. Thank you for watching sqadia.com.